start from your end first. Just let me know, then the particular person will be hand over. Take it from there. Sir, you will do or Arpita ma'am?
7:30 they told me. 7:30 if you give me 7:30.
Okay, fine. You we will be handing over to you first, sir. Fine. Ma'am, it will be fine, right?
Yes, yes, absolutely. Yeah.
Okay. Thank you so much, ma'am. We will be starting
Yes.
in just a go.
With all your due permission, we are beginning with the session for today. Good evening, everyone. This is Batul. I'm the assigned moderator for today's session, and I would like to welcome all the participants who have joined our platform for the better exchange of knowledge that is going to be shared by our keynote speaker doctors for today's session. And they are none other than very renowned doctors present with here, Dr. Panchanan Shahu sir and Dr. Arpita Joshi ma'am. With great honor, I would like to welcome both of them at our platform. Dr. Panchanan Shahu sir is MD in medicine, DM in cardiology, FISE, FICC, FACC, interventional cardiologist at Kalinga Institute of Medical Sciences, Bhubaneswar. And Dr. Arpita Joshi ma'am is MD, DNB, consultant at Joshi Eye Hospital and Psychiatric Clinic. With both of their expertise and both of their help, we'll be taking a close look on today's topic, which is dementia and atrial fibrillation. Before moving on to today's session, let us have a brief look on what the topic says. Atrial fibrillation is a common condition associated with cardiac arrhythmia. In recent years, several studies have shown that AF is a risk factor for cognitive decline and dementia. These studies have found a link between dementia and an increased risk of stroke. Other mechanisms that can contribute to this association are silent cerebral infarcts, microbleeds, and cerebral hypoperfusion. Now, without any further delay, with their all expertise, we would like to welcome Dr. Panchanan Shahu sir so that he can share his views on this. Sir, the forum is all yours. Over to you. Please proceed with your talk.
Thank you. Yeah. Am I audible? Good evening.
Yes, sir, you're audible. Please share your screen.
Yeah, my screen not visible.
No, sir, your screen is not visible.
Sorry. Yeah. What happened? I don't know.
The share screen option, so that is there. Just click on that.
Hello. Screen option, I have to go again, I think.
Yes. Just share your screen again.
Yeah. Yes. Share screen.
Yes, I can see your screen, sir. Just minimize this and open to the PPT presentation that is there.
Is it visible now?
Sir, you have to minimize this and you have to open your PPT presentation. Right now I can see. Right now I can see the Zoom.
This is PPT presentation I have opened. Is it visible?
No, your PPT presentation is not visible, sir.
So what happened? So I'll stop share. Sorry, madam, is it visible now?
You have shared your screen, sir. I think it's taking time to load, maybe.
Oh, sure.
Share it once more, sir.
Yes, leave meeting. I have to leave meeting. And
I think sir is facing some difficulty with his sharing option. I'll just connect with him. Just give me a minute now. Sir, am I audible?
yeah.
Yeah, please turn on
Yeah.
your camera.
I am not visible, I think. Am I
No, your
audible?
camera is off. Yes, you are audible. Your camera is off. Please turn it on.
Yeah.
Yes.
It is on.
Yes, yes. Now,
I have to
now
share
it is
again,
on.
I think. Share.
Yes, yes. You have to share it again. Just minimize this option, sir. That is there in front of you. Just minimize this bar.
This bar.
Yes, just minimize.
No,
Yes, now go back to your PPT presentation. Yes, click on it. Yes,
Yeah.
it is open now. Just make it full screen, sir.
Okay, fine. Am I audible and visible?
Yes, sir, you're completely audible and visible. Please start with your PPT presentation.
Good evening, all viewers. I give my thank and gratitude to IGCP group for giving me the opportunity to speak on this forum of dementia in atrial fibrillation. I have talked several occasions on this topic. It is a favorite topic when we talk on atrial fibrillation and other aspects. But it is fascinating. This time I was requested afford the talk to talk on dementia in atrial fibrillation. Of course, we know dementia occur in several cardiovascular diseases, ultimately leading to dementia. So, as we define dementia is a global loss of mental function and overall global cognitive ability. So, different types of dementia, as we explain, Alzheimer's disease, vascular dementia, with a lot of cardiovascular diseases, the frontotemporal dementia, Lewy body dementia, and dementia with a Parkinson disease. And in stages of dementia, starting from MCI, mild cognitive impairment, which proceed to multi-domain MCI, amnestic MCI, non-amnestic mild cognitive impairment, all these progress to dementia. So dementia in cardiovascular diseases, most of which ultimately lead either through atrial fibrillation or even without atrial fibrillation through thromboembolism, lead to vascular stroke and ultimately lead to dementia. So in cardiovascular diseases, different cardiovascular atrial fibrillation, other arrhythmias, coronary artery disease and myocardial infarction, post-myocardial infarction cases. Besides valvular heart disease and congestive cardiac failure, congestive heart failure, and after different CV cardiovascular procedures, we see progressing towards dementia. So the dementia and cardiovascular diseases, previously I think CV disease was thought to be unrelated to dementia. But common CV risk factors related to Alzheimer's disease and vascular dementia. Some common diseases are associated with the Alzheimer's disease. Both dementia occur in a tandem and share common cardiovascular risk factors. So there is a large overlap between Alzheimer's disease and vascular dementia caused by different cardiovascular diseases or cardiovascular disorders. The presence of ApoE4 allele is strongly associated with the cardiovascular disease as well as cognitive impairment and dementia. So there is a expanding body of literature implicating heart disease and risk factor for dementia. It is, although we are going to discuss atrial fibrillation, dementia and atrial fibrillation, different cardiovascular diseases which ultimately lead to atrial fibrillation, and atrial fibrillation is a common complication in many of the cardiovascular diseases. May it be a valvular heart disease, may it be coronary artery disease, post-myocardial infarction. It leads to atrial fibrillation, which initiate the process of dementia. There is an expanding body of literature implicating heart disease and risk factors for dementia. So the mechanism of dementia in development in atrial fibrillation. In atrial fibrillation, there is a decreased cardiac output. Because of the variable stroke volume, the cardiac output decreases. There is increased ventricular rate. Atrial fibrillation many times end in a fast ventricular rate, and this atrial fibrillation due to decreased cardiac output and increase the rate, increase in the incidence of cardiovascular severe cardiovascular accident and transient ischemic attack. And atrial fibrillation leads also to hypercoagulable stress because of the enlarged left atrium and stasis of blood in the left atrium, particularly left atrium. There is the stasis of blood, initiation of the clotting formation, which ultimately can lead to a cerebrovascular accident due to embolization. So thromboembolism is a very important complication of atrial fibrillation, which lead to development of stroke, severe, or sometimes we tell it is a TIA when the smaller or very small part of the brain is affected. So the hypercoagulable state in atrial fibrillation lead to neurodegenerative changes in the white matter of brain. Besides atrial fibrillation, other cardiovascular diseases, as I was telling, cardiovascular diseases, which separately can cause increased thromboembolism or can cause atrial fibrillation, which initiate the dementia process. Some studies have reported that there is a higher risk of a cognitive impairment after myocardial infarction due to brain hypoperfusion, and a cross-sectional evaluation in the Rotterdam study showed a positive association between cognitive impairment and prior myocardial infarction. Those with myocardial infarction also share a genetic background with Alzheimer's disease involving abnormalities in cholesterol metabolism and an upregulation in the inflammatory process. Honolulu aging study found no association between MI and later cognitive impairment, but many studies show relation between MI, post-MI, and dementia. Dementia and valvular heart disease. I was telling valvular heart disease. In many of the conditions, there is a increase in the arterial size. There is a stasis of blood. There is a hypercoagulable state, and lead to dementia. The Bordelos and colleagues concluded that left atrial dysfunction, dilatation and dysfunction increased with chronic mitral valve disease, contributing to atrial fibrillation, thereby increasing risk of dementia. So the valvular heart disease is a common risk factor for developing atrial fibrillation, which initiate the process of dementia also. And heart failure and dementia. In heart failure, according to Heart Mind study, participants with both heart failure and coronary artery disease were found to experience similar decline in cognitive function. So both patients of CAD or coronary artery disease and heart failure, they experience similar decline in cognitive function versus non-controls with heart failure but not coronary artery disease. Reduced cerebral blood flow seems to worsen cognitive impairment associated with heart failure, and those with a heart transplantation had a restoration of cerebral blood flow and improved cognitive performance. So heart failure is also a risk factor for multiple cerebral emboli, which could lead to cognitive impairment. Besides hypertension and dementia, hypotension also related to dementia. Although hypertension is a risk factor for development of atrial fibrillation also, high blood pressure is a major risk factor for cerebrovascular disorders including stroke, ischemic white matter lesion, and cerebral infarcts. Less known that hypertension is an independent risk factor for dementia. The association between hypertension and the risk of dementia is prominent, and while a rare study failed to show this, the many studies correlate hypertension with dementia. Hypotension also due to decreased blood supply. Interestingly, hypotension has also been implicated in the development of dementia. Several longitudinal studies report that hypotension is a risk factor for dementia, but studies are limited to elderly population only. Diabetes and dementia. Diabetes is one of the strongest risk factors for dementia. Diabetes has been associated with increased prevalence of cognitive impairment. In Rotterdam study in 1999, diabetes mellitus was found to almost double the risk of dementia. There are several potential biological mechanisms underlying the association between diabetes mellitus and dementia, including the impact of diabetes on cerebral microvascular dysfunction and oxidative stress. In addition, the role of insulin itself may be important in the potential development of dementia and Alzheimer's disease. High cholesterol, smoking, and obesity also related to dementia. Amyloid plaques and loss of neurons, particularly in the hippocampus, are thought to be central events in the development of Alzheimer's disease. There are very limited number of studies on the association between smoking and risk of dementia. Recent meta-analysis of 19 studies by Anstey and colleagues showed that smoking is a risk factor for a cognitive decline and dementia. Obesity is a growing problem in a modern society and has been linked with the risk of dementia and cognitive impairment. Worldwide, low education is responsible for a largest contribution of obesity and dementia. Besides, diet and exercise also has a role. In a healthy diet, is one modality for prevention of heart disease, but studies have shown very mixed results for diet as an effective method for slowing cognitive decline in dementia. Exercise has been implicated in the prevention of cognitive decline and dementia, while studies on the exact relationship is still limited. Recent review, Roman and colleagues highlights several studies showing physical activity and exercise as being strongly associated with improved cognition and lower risk of cognitive decline in persons who do regular exercise. Besides atrial fibrillation and Alzheimer's disease, during aging, the prevalence of Alzheimer's disease and cardiovascular disease increase with aging. It may be hypothesized that there are various mechanisms underlying association between Alzheimer's disease and cardiovascular disease. The main ones being hypoperfusion, emboli, and atherosclerosis. So these three lead to both development of Alzheimer's disease. Furthermore, in both the heart and brain of Alzheimer's disease patients, amyloid deposits may be present, thus causing damage to these organs. So hypoperfusion, embolization, and atherosclerosis are important in development of atrial fibrillation and Alzheimer's disease. We need to clarify the real impact of these underlying hypothesized mechanisms and to investigate gender issues. So risk factor for dementia in atrial fibrillation, the frailty, low body weight, mood disorder, comorbidities associated with some medication and schizophrenia also have been correlated with dementia and atrial fibrillation being risk factors. Thank you. This is all I can tell about the role of atrial fibrillation or cardiovascular disorders, development of dementia. Thank you. Yes. Thank you. Am I audible?
Yes, sir. Thank you very much. It was a very nice and the presentation, and we got so many things, new things to learn. Over to you, Batul.
Thank you so much, sir, for such a wonderful talk and for such a comprehensive overview on such an important topic. We'll move to Dr. Arpita Joshi ma'am's presentation, and after that, we'll be taking the question answers from the participants. Ma'am, over to you.
Yes. So, give me just 1 minute.
Yes, yes, please.
Okay, so my screen is visible?
Yes, ma'am, your screen is visible.
Yes, it is visible. Then make it full screen.
Yeah, I have already made it full screen. Is it okay?
No, ma'am, your screen is not in full screen mode.
I'll start the slideshow. Is it okay now?
Ma'am, I cannot
Madam,
see
go
it.
to down to make it full screen, I think.
It's full screen.
Your
with
lap-
my
your lap-
computer. Yeah, I'm starting the slideshow. I'm not sure
Okay.
why it is not visible to everybody. It is full screen in my this thing.
Ma'am, if you can just stop share and share it again, I think there's a preview that you can see and we cannot see. Maybe that can be a thing.
Okay, fine. Yeah. Okay, I'll do that. So I have stopped that. Now I will start sharing.
Yes.
Is it visible now?
Yes, now it is
Yeah,
visible in full
now
screen.
it is full
Please
screen.
continue.
Okay, fine. So A very good evening to all the listening doctors. Sir has already described the basic things, what is happening inside our brain and the cardiac factors which are probably responsible for developing dementia over the time. So I will just emphasize on the required part of it. So how big this problem is basically. At present, a recent study which was conducted in 2022, it suggested that in the prevalence of dementia as such, it is almost 7.4% in population who are older than 60 years. So from this number, we can see how big is the problem. And from this bulk of dementia patient, approximately 40%, they are estimated to be due to vascular dementia. Like the causes are various reasons, vascular reasons for stroke, like this atrial fibrillation. So now, when a patient comes to the OPD and we diagnose a patient that is a new patient for atrial fibrillation, among all the patients, approximately 37% of the patients who are newly diagnosed cases of atrial fibrillation, they have already developed dementia at the very time of presentation. That is mainly because the lack of awareness may be, or that somehow we usually accept some sort of cognitive decline in elderly population as such. So often this is unnoticed and untreated till it reaches a severe clinical phase. So what happens inside the brain? Sir has already discussed it in detail, so I will just cut short it. Various risk factors like sir has said, age, hypertension, diabetes mellitus, hyperlipidemia, sleep apnea, other any vascular diseases, heart failure, chronic kidney diseases, alcohol consumption, and thyroid dysfunction. All these risk factors, along with atrial fibrillation, what happens there is thrombotic state, and due to reduced cardiac output, there is a state of hypoperfusion. So basically, this can lead to silent cerebral infarct. This can be a large infarct also. Then it might have the full-blown picture of a stroke, or there might be some very small micro infarct or micro emboli as such, which leads to gradual degeneration of the neuron. So, and AF also can lead to a state of inflammation, which again adds up to the picture. So all these things add up to when added with some already pre-existing genetic factors of other disorders or dementia as such, they lead to cognitive impairment and finally dementia. Another thing here is that some studies they have shown that the oral anticoagulants, mostly warfarin, when it is used and it is the time spent outside of the therapeutic range, because when we use warfarin, we have to be very careful about the INR. If when the time spent outside this therapeutic range, when it is greater, then it leads to microbleeds and ultimately adds up to the cognitive impairment problem. So again, mainly the cognition, behavior, and emotional part of it, all of it gets affected. And I am not going into details of this each and every clinical features, as I'll just stick to the important part of it. So basically, when we talk to vascular dementias or dementia because of atrial fibrillation as such, there is certain difference in the clinical feature with when we talk about Alzheimer's disease. So what happens? The onset is usually earlier than Alzheimer's disease. Typically, Alzheimer's disease, the patient present after the age of 65 years, but in this case, the onset may be earlier than that, and the onset can be sudden. Sudden in the sense, in Alzheimer's disease, it takes at least a couple of years to progress. But here, the dementia or the cognitive impairment, it can progress within a couple of months as such. And there can be a stepwise deterioration can be noted. That means sudden worsening of symptoms, then the symptoms get stabilized over for a period of time, then again sudden deterioration of the symptoms. So there is a step ladder fashion is sometimes it is observable. And in case of vascular dementia, the symptoms mainly depends on the site of involvement, the site of the brain which is involved first. If the frontal part is involved first, then all the executive functions and the personality changes, emotional instability, these are more prominent. If the parietal lobes they are involved first, then apraxia, agnosia, and all these kind of symptoms, they are more prominent. They comes in the beginning. So this is how it is a bit different from the classical Alzheimer's disease as such. So what can we do for these patients, or how to pick up on those things? So the how to screen for this patient for dementia. So when a patient, what should be done is, when a patient is diagnosed to be having atrial fibrillation, we can go for a screening for dementia. And the most commonly used the tool which we use is MMSE, that is Mini Mental Status Examination. It is a very easy to administer. It takes hardly 15 to 20 minutes. And a doctor or a practitioner may not administer it because it is very easy. We can teach it to our staff or nurses, so they can administer that. And there are 30 questionnaires, and out of 30 we give the patient the scoring depending on how they perform. So basically, how to interpret the score: if the score is 25 or more, then it is suggested that there is no cognitive decline as such. We would like to, and there is no deterioration in day-to-day functioning. We would like to keep on screening the patient every 6 months. If the score is 20 to 24, then it is then the degree of impairment is mild. That means the person, they are having mild cognitive impairment. If the score is 10 to 19, then it is considered that they are having moderate impairment or moderate disease. If the score is less than 10, then they have severe dementia. So how to further diagnosis the case, how to further assess the case? So the assessment purpose is mainly diagnostic, functional, and social. So a detailed history like any other disease should be taken. And MSc is mental status examination. It should be done because along with dementia, many of the time depression and psychosis, anxiety, other psychiatric disorders are also very common. So a thorough mental status examination should be done. Cognitive testing should be done because to determine which part of the brain is more affected and what kind of assistance the person will be requiring in future, the probable progression of the symptoms and the probable planning for the further treatment in the future can be more accurately done if we do this cognitive testing, so that we know which kind of functions they will be finding difficult to do. And IQ code is, that is basically informant questionnaire. That is the person who are taking care of the elderly. They are given this questionnaire, that is informant questionnaires for cognitive decline, when the persons, they are not able to take a test, or in severe to moderate to severe cases. Functional assessment further is done by various other scales like Bristol Activities of Daily Living Scale and Berthel Index. So after that, a few blood tests which are very important in these cases, because even simple cases of anemia, or if the blood urea level is increased or thyroid is low, there are few reasons for dementia which are very easily treatable. When they coexist with already a cardiac patient, then the risk become much more higher. So CVC, LFT, RFT, ESM, this should be done. Any anemia should be corrected. Thyroid is one more important thing, because we get patients of full-blown symptoms of usually elderly ladies with dementia, but when the reports come, they are having they are diagnosed to be as a case of hypothyroidism. When they treat it, the recovery is almost like a miracle. So this, we should always screen for these things. Calcium, magnesium, phosphatase, again VDRL and HIV, they in later phase of this disease, they affect our brain and they can give rise to a dementia kind of picture. Vitamin B12 and folate deficiency, again in severe deficient cases, they can present like a case of dementia. So these things should be always ruled out. Now, brain imaging, the MRI is the standard investigation which we regularly go for. So it shows the silent brain infarcts. It can focal atrophies and markers of the small vessel disease. It can catch on. Excuse me. And other investigation which we can do, these are PET scan and SPECT scan, which can detect the reduced blood flow and reduced oxygen supply to the part of brain. So these are few things which we can do to further confirm our diagnosis and to determine the extent of the disease. Now coming to the treatment part of it. Now, before starting the treatment, we have to keep it in mind. We cannot cure dementia. We cannot even stop the progress of disease. What we can do is we can only slower it a little bit. We can only slower the process a little bit. And the main goal of the treatment is to improve the quality of life. So when the diagnosis is early and the other interventions are done in proper time, it improves the quality of time, not only of the patient, but also to the caregiver. Because dementia, it is a huge burden to carry for the caregiver. In our Indian settings, most of the time, usually the family members, they're the one which plays the role of a caregiver, unlike the Western counterpart of it, where the institutionalization is more frequent and more common. So, to reduce their burden also, to improve the quality of life, the patient as well as the caregiver, it is important. And another important thing is that when the person in the early stage of the disease, in mild cognitive impairment or mild cases, so when we give them the diagnosis, there are so many emotional consequences for the patient also and for the family members also. So counseling and psychoeducating can ease this phase so that the patient, they can take the diagnosis, receive the diagnosis in a better way. And also a few practical aspects of it, like it allows the patients or families to make informed choices about, they can plan for the future, any legal power of attorney, distribution of the property and other things can be taken care of in proper time. So now coming to the treatment part of it, mainly in four major groups are there. First of all, the pharmacological management, then some behavioral interventions for the patient, the environmental modification, and caregiver support. So, in pharmacological management part of it, the acetylcholinesterase inhibitors, they are the main drug of choice as of now, and these four are the US FDA approved to treat dementia. These are donepezil, rivastigmine, and galantamine. They are ACE inhibitors, and NMDA receptor antagonist, that is memantine, which is the newest drug in this category. So now the NICE guidelines, it says that before starting a treatment, a person's MMSE score and cognitive function must be tested and it must be noted down. So when we start the treatment with donepezil, rivastigmine, or galantamine, these three are reserved for mild to moderate diseases. When we start, we should note down the MMSE score, and we should again assess the patient within the time span of 2 to 4 months, and again note the MMSE score. If there is any improvement in the MMSE score, or at least the MMSE score is same and the caregiver they're reporting some improvements, then and then only we continue the treatment. If there is a decrease in the MMSE score, even with the drugs, then we consider the next step of management. And there comes Nimantin. It is reserved for the moderate to severe phase of the disease. So, when the disease in the moderate to severe phase, we start with Nimantin, and donepezil and Nimantin combination is also available in the market. So, again, the same thing. We start with the medicines. We take again the MMSE score we counted after within 2 to 4 months. If there is signs of improvement, we keep on continuing the treatment, and every 6 months we keep on checking the MMSE score and for the cognitive functions. At any point of this treatment phase, if the MMSE score it's come below to the level 12, the score comes below the level 12, then it is determined that this particular drug management is not working anymore and the disease has progressed to the severe phase. So we stop these drugs. So this is the basically in short the nice guidelines for the pharmacological management of dementia. Now, coming to the other pharmacological agents, what we can use for this patient, what other treatments? Other treatments are like antidepressants and antipsychotics, because as I said, depression and psychosis, they are again very common in dementia patients. So in antidepressant, escitalopram is a choice of drugs because it doesn't interact with the other drugs. So, and if the person they are having any sleep difficulties, then nafazodone or other antidepressants, which are also sedative in nature, these are usually prescribed. In antipsychotics, risperidone is the drug of choice, which works good in elderly population. So to control the psychosis and all these things. Ceticoline, again, another very important drug, which is specifically helpful for vascular dementias, post-stroke dementias. It really helps to improve the cognitive functions. In my personal experience also, we have seen so much improvement in the cognitive functions after using this ceticoline. Cerebral protein hydrolysate is another drug which is again very commonly marketed, easily available for treatment of dementia. Cerebral lysate. Estrogen is again another drug which is used as a patch. The dose is 0.1 to 1.25 mg per day. So these are transdermal patches. We just need to stick it on the skin. And many studies, they have shown improved cognitive improvement after using this. Ginkgo biloba. So basically, these are all acts like as a nootropics. So now, coming to the behavioral interventions part of it. So the most important one is cognitive stimulation. Cognitive stimulation like structured therapy is also available, which can be done with a trained therapist. And even structured therapies are not affordable or not available to some patients. They can also try to do some few things like the caregivers. They can play with the person simple card sorting games, like they can play it with a deck of cards, and you just separate the cards according to the colors, maybe according to the numbers, depending upon their level of cognition. Small things like that can be done at home. And environmental modification, I will come back to it in detail later. So massage and touch therapy, these are also have proved to be very helpful. Occupational therapy, again, to help the patient to achieve functional independence, because as the time goes, they will find difficult to perform day-to-day activities like buttoning their shirt or combing their hair or put on their shoes. So occupational therapy, it really helps to manage this part of it. Social interaction always should be maintained, or the care with the caregiver support or with the support of the family members as much as their health condition allows. Exercise is again another very important thing. So depending upon their physical condition, some sort of exercise they should be encouraged to do. Multidisciplinary care, the caregiver should know whom to contact in case of any emergencies, whom to contact to seek for a specific kind of help. Psychotherapy, usually it is reserved for the mild cognitive impaired patients or the early part of the disease. Counseling, validation therapy to understand the patient's emotion and to teach them how to live a better life with all this problem. And reminiscence therapy, that is any activity which can give reminder of a patient past of the family members, like they can try to spend some time while looking at the older pictures of the family members and try to identify who is who, and try to reliving the moments, like some with the help of some picture which was maybe taken during some vacation or things like that. So it acts as some sort of reminder. So that is what reminiscence therapy is. Animal therapy, again, another thing which is coming nowadays. The pet therapy or pets, or they are very much helpful to control the anxiety and agitation in this kind of patients. Now, the environmental modification I was talking about. So this is specifically helpful in the moderate to moderate phase of diseases, because the person, they get confused. If they're hungry, where to go? Where is the kitchen? Where is the bathroom? So when as the disease progresses, it becomes difficult to find all those things. Even in the home they have lived throughout their whole life. So what we can do is we can put some visual cues or indicators that that the toilet is this side, like just like when we go to some public places to visit, if we need to use the toilet, we look for this kind of visual cues or signs. The same kind of thing. A few examples are there, like in toilet also, this kind of tape. So they can remind to aim more accurately, where to sit and what to do. So like their clothes, the different item of clothing, like socks are there and underwears are there, shirts are there, like that. And this kind of tape in case of can highlight the threshold, so they can avoid trips or fall down, which is again very common in this kind of elderly patients. And usually the room of this elderly patients should have a clock showing the time, a calendar showing the date, and windows or skylights which can provide daylight or a glance to the outside what is happening. Because with the progression of this disease, sundowner phenomenon is again very common. It is like during the evening time, the patient gets agitated repeatedly. That is mostly because during the evening time, the sensory inputs, they reduce. The light is gone, interaction is gone. So due to this kind of sensory deprivation, they get confused, and any confusion in this kind of patient, it leads to agitation or aggression. So this kind of things should be taken care of, so the confusion is minimum, or whenever they're confused, they can take cues from the outside and surroundings, and they can understand the situation better. Now, the last thing is caregiver support. Like I have already said, it's a huge burden to the caregiver as such. So if a family member is the primary caregiver, they have to maintain their life also. It shouldn't be such a burden that they're suffering. So the quality of life of the caregiver as well as the quality of care for the patient, everything is suffering. It should not be like that. So the proper counseling, and they should psychoeducate regarding the disease progression, what to expect from the patients, and in case of, they should be very much informed with all the emergency contact numbers, whom to attend and whom to go, whom to ask for help when this kind of emergency arises. So now in India, telecounseling helpline for mental health, which is telemanus, which is recently started. So there's a toll-free number. It helps the caregiver also and the patient also. And there are so many different groups, self-care groups, self-help groups for this dementia patients in India, depending upon the cities. So from where we can seek help. One of them is like ARDSI, which is Alzheimer related disease Society, sorry, of India, which is based in Hyderabad, which is again working so nicely. So many NGOs and self-help groups, they are available. So we can try to learn and search and find out who those groups are and contact them. Now in today's era of social media, so many social media groups are available for this dementia patients also and caregiver also, in Facebook, in Instagram. So we can get connected to those people, we can share our experiences, and we can always help each other. So this is in short how to treat a case of dementia, how to go about it. Now another important part is prevention. So basically, whenever a patient who are having a risk factor for dementia, like any first degree blood related with dementia, or the patients who are diagnosed with any kind of heart ailment which increases the risk of dementia, they can keep a few things in their mind which can help, which can protect them against dementia. So these are basically, like sir has already said, healthy lifestyle is very much important. Good exercise, diet, proper sleep, and is important thing. Quitting alcohol and smoking or other any substance abuses is another very much important. Apart from that, few things which extra which we can do is that we can always try to challenge our brain. The way, to increase our body strength, we go to gym, we do exercise, we increase our muscle bulk. So that is what, to increase our strength, body strength. We do same kind of thing we can do with our brain, because when we keep on challenging our brain, so the neuronal connection, they actually increase in number. This particular phenomenon is called synaptic plasticity. So there is increased number of synapses. So there is increased number of newer neurological pathways which actually keep on developing throughout our whole life, depending upon which kind of exercise we are doing with our brain. So in dementia, any kind of dementia, the ultimate pathology is we are losing neurons, we are losing nerve cells, we are losing synapses. So by continuously keeping on challenging our brain, we try to increase the number of synapses, the number of pathways. So we are already trying to increase our cognitive reservoir. So when the disease attacks, we are having much more bulk of this cognitive reserve, even if it get affected somehow by the disease, but ultimately it won't reach to the severe phase of it. So this is one very much important thing we can do to improve our cognitive reservoir. It is nothing fancy or any fancy thing we need to do, or we need to visit to any therapist or seek help of any kind of professional. These things we can do on our own at home. We can try to learn maybe a new language. If that is also not possible, it's okay. We can try to, the ladies, they can try to, cook a new dish, or by simply playing Sudoku or any games in our mobile, or doing crosswords, or reading, or even approaching our life in a different way. In different way means, most of us, we are right-handed. So when we try to use our left hand predominantly, consciously, to do things, new connections, new synapses, they start getting developed in our brain, definitely over a period of time. So like that, you start doing things with your left hand, start practicing writing with your left hand. So things like that will challenge our brain, and definitely will increase the number of synapses and connections and pathways in our brain, and ultimately improve our cognitive reservoir. So that is one thing we can do to improve our cognitive reserves, and to protect ourselves against dementia. So that is all in short about dementia in case of atrial fibrillation and dementia as such. So now if there are any questions, I will be happy to answer those. Thank you.
Thank you so much, ma'am, for such a beautiful talk and such a wonderful insights that you have shared upon the topic. Sir is also here with us. So with all your due permission, I would take the questions that we have received from the participants and would like to know your point of view. So I'll be detailing the questions, and one by one, you can give your point of view on it.
Yes.
So the first question that we have received is the first question is there any association between atrial fibrillation and dementia?
Between access.
Sir, your voice is not coming clearly. Could you please be a bit louder?
What is the question? Accessibility of dementia.
Yes, the question is there any association between atrial fibrillation and dementia? What is your view on it?
Yes, already I have discussed that, because in atrial fibrillation, the mechanism of development, because there is a microthrombi formation due to stasis of blood in the left atrium. There is a stasis of blood, microemboli formation, and which can embolize into the brain, cause microembolization in form of a TIA or small infarct. So it is not only in the atrial fibrillation, other cerebrovascular disorders also I have described: heart failure, valvular diseases which lead to atrial fibrillation, even without atrial fibrillation, with heart failure, can lead to dementia. So atrial fibrillation itself, by stasis of blood, by microembolization, by causing microthrombi, microinfarct in the brain, can cause. Although we are not treating a plain case of atrial fibrillation with to prevent dementia, we are treating atrial fibrillation to control the heart rate, to keep the patient in stable condition. So the means of developing dementia in atrial fibrillation, as I have told you: blood status, microembolization, microinfarct formation is the way.
Thank you so much, sir. Ma'am, what is your take on this? Would you like to add something?
Nothing new to add. Actually, the whole presentation was all about it. Sir has already explained in detail, and I have also said what happened in case of atrial fibrillation and how it affects our brain and how it develops dementia. Sir has mentioned so many studies also, which also prove his point. So nothing new to add.
Thank you so much for both of your point of views. We'll move to the next question, and the question is, which implications are needed for dementia patients?
Okay, I'll go. Implication means I couldn't understand the question properly, what they actually want to know.
Which implication?
I would request to reframe the question and send it to us so that we can put it across. Till that time, we'll move to the next question. And the next question is, what cognitive impairment is associated with atrial fibrillation?
Cognitive impairment that MIC, minimal cognitive disorder, MCA, minimal cognitive impairment. So when we are facing a patient of atrial fibrillation from the beginning, lately, initially we don't mark anything, but patients who maintain a long atrial fibrillation or chronic atrial fibrillation, or those who go to permanent atrial fibrillation where there is no scope to return to normal sinus rhythm. In patients over years and decades, I have marked some amount of cognitive disorder. Of course, in normal patients also tell those forgetfulness and keeping their work in order. Say they complain sometimes. In the long-term follow-up of atrial fibrillation, those patients come for years and decades. In them, I am marked. So the cognitive disorder, because of frank psychotic disorder or frank memory loss, we send them to a psychiatrist. In our level, different types of cardiovascular disorders, which we treat, and many of them, they end in atrial fibrillation, and some valvular disorder atrial fibrillation, heart failure atrial fibrillation, or patient of hypertension going to atrial fibrillation. In those patients, we try to prevent by giving certain anticoagulants. Nowadays, we have some Chadha score, one scoring system. So when all these are associated, heart failure, hypertension, diabetes, vascular disorders, we do a scoring system. In male, if it more than 2, and in female more than 3, then we treat them with anticoagulants. Anticoagulant means we either a vitamin K antagonist or the newer NOACs we are treating to prevent any microembolization to the brain, so that the patient will remain for a long time healthy from cardiac point and from cerebral point of view. So we treat the patient to prevent atrial fibrillation. Not that we are treating to prevent dementia, but by our treatment we prevent dementia by treating the disease itself.
Thank you so much, sir, for your point of view. Yeah, we'll move to Dr. Arpita. Ma'am, your view on it?
Yeah. See, all kind of cognitive impairment we can see in this type of patient. Like I have already said, the newly diagnosed cases of atrial fibrillation, approximately 37% of them, they're already having all the signs and symptoms of dementia. And basically, dementia, it is a syndrome which is characterized by a global cognitive impairment. In these cases, usually the memory impairment is the first one which we notice or the family member they notice. But most commonly associated with that, other cognitive impairments, there are dysphasias, agnosias, apraxias, and there is executive function. It is also impaired, and personality disintegration. It comes at last. So all kind of cognitive impairment can be seen depending upon at what stage of disease they are.
Thank you so much, ma'am, for sharing your wonderful insights. We'll move to the next question that we have received, and this question is, can atrial fibrillation cause delirium?
Delirium.
If Dr. Arpita, ma'am, you want to go first? Yeah.
Yes, definitely it can cause delirium. You see, delirium again is very commonly found in case of dementias, in moderate to severe cases of dementia. and usually the same mechanism which causes the dementia. That is, at any point of time, the brain oxygen is reduced, the blood flow to the brain is reduced due to compromised cardiac output. So again, it can lead to delirium. Definitely, delirium is very commonly found in this kind of cardiac patients and in dementia.
Thank you so much, ma'am. Sir, would you like to add something on it?
Yes, delirium, not only it is the atrial fibrillation, delirium is a common presentation to cardiologists. Of course, they tell most of the time a reeling head or falling sensation, pre-syncopal attack. These are common. So we find out whether he had atrial fibrillation or sometime having paroxysmal atrial fibrillation. Some patient will develop a paroxysm of atrial fibrillation for a few days, few hours or few days, and they'll complain of I had some bad occurrence, reeling head, fell down, or about to fall down. So the reeling caused by various cardiovascular disorders, one of them is atrial fibrillation. It is not a, I don't feel it is a psychiatric disorder, delirium. It is something, a reeling or a tingling like sensation patient feel.
Thank you.
Arpita madam, what is your opinion about, is it some psychotic disorder?
It's not psychotic as such, but the
Not,
thing is,
not
what happens in delirium, the most common clinical feature is that patient is disoriented to the time, place, and person. And because they are disoriented, they are not able to understand what is happening. Many of the time they get agitated or they get even aggressive. And that is what in delirium is the altered, what we call is altered state of consciousness, when the patient is not oriented to time, place, person with all or anyone, and another is their attention and concentration is severely impaired. So most of the ICU visits or ICU call we get is the patient, their cases of delirium. That is very common cause for the call of a psychiatrist to the ICU. So it is a short-term ailment, definitely, as the causative factor, as it is treated successfully, it goes away.
Thank you so much, ma'am, for adding your valuable insights upon the question. That was the last question for today's session. And with this, I would also like to thank both of you for taking out your valuable time and for being here at our platform and sharing such wonderful insight with the audience. Thank you so much. We'll be looking forward for such interactive sessions from your end in near future. With all your last comments from both of you, we can conclude the session here for today.
Thank you. Thank you very much.
Okay, so I would like to say it was a nice interactive session, and I also get to know Panchanan Sahu sir. That is also a good thing. And I would hope that this our session of today, it helps our doctors, listening doctors, to treat dementia patients or when atrial fibrillation patients come, so that they screen them for their cognitive impairment also, and so that the further complications can be taken care of by timely intervention. So that is our goal and our hope from this today's session. Thank you so much.
Arpita ma'am. I just explained the cardiovascular causes, but you gave the details about the treatment also, approach to the treatment and some of the treatment, because most of the patient atrial fibrillation we don't treat for dementia.
Yes.
We only try to prevent dementia. Yes. So that, but when it goes to the treatment level reaches you, the drugs that Donem or something like the drugs you have given, you are treating with drugs. We usually are not using those drugs. We are only trying to prevent to develop dementia. Thank you. It is a very nice session.
It was my pleasure also, sir. Thank you so much.
Thank you.
Thank you and good night, sir.
Thank you. Good night. We are closing for today.
Yeah.
Thank
Thank you.